Hello guys, very good morning. This is Dr. Ranjith, your pathology educator at Unacademy. So here we are going to read something which is very fresh and new to the entire world. We're going to read about WHO 2021, the updates in the CNS. Because as you might have known that the WHO keeps re-emphasizing all the important points of the tumor every 4 years. The last 2016 classification of CNS has been taken a hit, and they have changed a lot. They have introduced more than 20 plus new tumors. They have changed their way of reporting. They have changed from the Roman numericals to number 1, 2, 3 and 4. They have changed the structure of reporting. They have called something as layered reporting. And waiting for the book to come out. Just the article has come out as of now. The book says that there will be essential criteria and desirable criteria present for every tumor. That will make our life much more easier. Fine. So what we are going to do is we'll have multiple videos on the update of WHO 2021, and I hope I'll have a live class session as well for you guys, because sometimes it will be easy for us to discuss in the live rather than just having it as a video. Fine. So in this video we're going to have the update, the first update of WHO 2021 CNS, especially for postgraduates. Maybe I'll use the highlights of the update and I'll share it with you on the Telegram group for your undergraduates as well for your NEET exam. Might not come for INISET, but definitely it might come for the NEET exam, because last time when the update came in WHO 2016, the glioblastoma, the multiforme removal, became a big question. So something of that might come here, because now also there's a change in glioblastoma. They have said that if it's a pediatric tumor, high grade tumor, don't use glioblastoma. They have reclassified entire pediatric tumors. Let's go ahead and see it. Okay. There's an article which has come, and these are all the tumors newly recognized. It's an incomplete list. There are a few more. I cannot put it in an entire screenshot, so I put it here. Right? There are more than 20 plus tumors which have been newly recognized, and they have changed the name from the older editions. The emphasis has become totally molecular. Rather than having an microscopy based diagnosis and IHC based diagnosis, they are slowly shifting towards molecular. We saw this trend even in WHO 2016 of the CNS, right? Now it's become more towards molecular. I think we will have a scenario down in future where we will not be able to diagnose any cancers without molecular genetics. Hopefully that will come. If that comes, the errors of reporting might reduce a lot, because sometimes the pleomorphism or the mitosis, it might be a difference between pathologists. When I say it is mutate for Ewing sarcoma, it is Ewing sarcoma. So the difference of opinion will come down. The inter-individual variationship will come down. So it will be a better clarity in the diagnosis. Will be useful for the patient as well. Fine. So in this, what you're going to see is how the pediatric gliomas are redefined. We'll see about the low grade and high grade group of pediatric gliomas, and maybe we will be seeing about one tumor from low grade and one tumor from high grade. And the subsequent videos will cover all the new entities, because many tumors in the low grade and high grade glioma group are new, and many of them have been reclassified, renamed as well, right? So as such, pediatric glioma was not an important entity in the previous edition, where the concentration was predominantly the adult gliomas. Now pediatric glioma was also being recognized a lot, and they also said that it's more important because pediatric gliomas, if I'm able to take care of them, the prognosis is not as dismal as in adult gliomas, right? Though it may look bad in microscopy, the molecular genetics is good, and there are few drugs which have been developed on the go which might help in the management as well. So low grade glioma has 4 tumors and the high grade glioma has 4 tumors. That's how they are divided. There are 4 tumors in low grade glioma, and all these are new tumors. The polymorphous low grade neuroepithelium of the young. I have a case on this. I've taken 2 cases. Both of them are from the articles. One is from the article which released, which has the entire WHO 2021 update, and one more from the reference article. I have diffuse astrocytoma MYB related. Before them, we were calling them an isomorphic midline gliomas. The isomorphic midline gliomas now has been kind of, which has MYB alteration, they come under grade 1. So the isomorphic midline glioma, though they look pleomorphic, they became very subtly. So they have reclassified them to low grade group with MYB alteration, so they have a better prognosis. Same with angiocentric glioma and a diffuse low grade glioma, MAP kinase pathway related, right? And we have a diffuse high grade glioma with another mutation related. Okay. So these are the 4 tumors which comes in the low grade groups in your pediatric gliomas in the new classification of WHO 2021. When you come to the high grade group, it's diffuse midline glioma. Like I said, that there's a low grade glioma, there's a high grade glioma. The mutation is different. That is MAP kinase pathway mutated. Here's H3 H3, this H3 will keep on coming. These are all histone modifications. This WHO has been said that the major change which happened was in the methylation studies. I'm going more towards epigenetics, moving from genetics to go towards more epigenetics. All these histone modifications, why I'm moving towards epigenetics is, or the methylation studies is, I might alter them, because all these are reversible changes, unlike a mutation which is a permanent change, right? So H3K27 altered, diffuse hemispheric glioma, we have a case of this, H3G34 altered, okay, and diffuse pediatric glioma, again H3 wild type, IDH wild type. I'm sure you know what wild type is. Whenever you use term wild type, it is not mutated, right? So non-mutated for H3, non-mutated for IDH, I call them diffuse pediatric glioma. I have an infantile type hemispheric glioma, right? These are the 4 terms, 4 new classifications, and most of them are new here and few of them are reclassified. And the major update here is, do not use the term glioblastoma for a pediatric population. Don't use the term glioblastoma, because though it's high-grade glioma, I'll have an update here. The H3G34 mutation has a targeted therapy. Right, we'll just have a look about them. That's why I'm saying that the prognosis is not so dismal compared to an high-grade glioma of the adult. So I'm trying to reclassify them, segment them molecularly, so that I'll be able to target them specifically with this tumor. So maybe the prognosis will alter, right? So we'll have 2 lesions here. The one is, I said, the polymorphous low-grade neuroepithelium of the young. The abbreviation is known. I want you to know the abbreviation, fine. As I said, I have 2 cases. We'll look at both the cases, and then we'll look at the explanation of the cases, the morphology as given in the reference articles, and also the IHCs, right? So this was given in the article which gave all the difference. So it's one thing, if you look at the first image, what it looks, it's looking like a small round cell, and it looks, few of them has kind of a perinuclear halo, right? Kind of has an oligo, like especially here in this corner, there are 4 cells or 5 cells here. All of them have a perinuclear halo. Kind of looks like an oligodendroglioma like morphology, right? So the oligodendroglioma like morphology. The most important thing here is, look at the second image. It doesn't look good. It doesn't at all look good. So it said that this polymorphous, that's why it's termed polymorphous, right? It's not pleomorphic. We call them polymorphous. Polymorphous low-grade neuroepithelium of the young. The reason why this becomes very, very important for me is, if I'm going to report it on a histomorphology, I will say that it is atypical. When such an amount of atypical is present, obviously I'm going to push them into grade 2 in the previous classification. So it's not a grade 2. Though it looks bizarre, I do have a little bit of pleomorphism. That's why I named them polymorphous. It's not pleomorphism, it's not atypia, it's not the high grade nature, it looks ugly, that's all. And we said that, okay, this is how the tumor is going to be. And the most characteristic finding here is CD34. All these tumors are CD34 positive. It's not only a tumor, the figure D given here, it's actually not the tumor, it is there. It's seen in the surrounding brain parenchyma. Even the surrounding brain parenchyma, the CD34 is going to be highlighted in the neurites. So what they are saying is, CD34 is kind of a stem cell marker. So stem cell expression in the neurites are becoming more, so they become more proliferative, that's all. And they are seen in pediatric age group. In spite of the intracellular variation, I'm going to report this in low-grade glioma, and that this glioma has been categorized under WHO1. Fine. Okay. Second case, again the same case. I'm going to take it from a different journal, Clinical Neuropathological Journal. Same. The first image you look, it's monotonous population. It's not the same image, but a different case. It almost looks the same, right? So it's identical. Even between the case also, I don't have much of a variation. Again, I have cells which is a classical oligodendroglioma like morphology. That's more promising here. So I should not mistake it for an oligodendroglioma and do my 1p19q deletion, which might not be present here, right? So there is kind of a morphological overlap which can be sorted if I know the lesion and if I can diagnose them, right? Again, the second image, they look pleomorphic, right? Though here also I can see the classical oligodendroglioma like morphology. The background fibrillary cytoplasm is still maintained, but I do have a little bit of pleomorphism, so I'm going to be worried whether if it's malignant or not. So in spite of the pleomorphism and the same intertumoral heterogeneity, I'm going to think of a low-grade glioma only. Once you know this, definitely we'll do on CD34. See, CD34 is diffusely positive. Again, CD34 is not a marker which is rare, which can be easily available in most of our hospitals. I can apply that. Same thing, a journal also gives an image that This is the normal surrounding brain parenchyma. The normal surrounding brain parenchyma, which may be like the preneoplastic lesion, it's also expressing more amount of CD34. So that's a characteristic finding here. It's not only the tumor, the surrounding brain parenchyma, astroglial cells also will have an elevated CD34 expression. Okay, we saw two cases for this thing, and let's go ahead and see what they describe in the tumor. It's a WHO grade 1 tumor. It's as an infiltrating pattern. And this is again more classical. When I say WHO grade 1, we always say that it's a defined lesion. I can take it more, right? They do have an infiltrating pattern, but still they are WHO grade 1. So definitely, if I don't know this entirety, because of the infiltration, the polymorphism, we are going to upgrade the lesion. So knowing this entirety and giving a better diagnosis will aim at a better prognosis for an infant, right? And as I said that, we also appreciated that we had an oligodendrous glial cell like problem, right? At the perinuclear halo. The most important thing is the intratumoral heterogeneity. Lots of variations. Uniform small rounded cells can be there, perinuclear halo, something kind of sprinkle grooves as well, right? We didn't see grooves, but definitely we appreciated the pleomorphism for sure. That's why we use the term polymorphous. We are not calling it pleomorphism very with thoughtful nature. We use the term polymorphous. So it's not actually the atypia, it's the appearance looks different, that's all. Pericapillary pseudorosicting was also noted in few, though it's not a characteristic finding. In spite of the pleomorphism, in spite of the infiltrating pattern, web index or McKay is less than 5%. Most of them is less than 5% in spite of the variation. So definitely it is a low grade lesion. So if you have seen any case previously, I want you to look back at the case, apply a CD34, maybe I'm going to reclassify the case. You can do that. You can do that and you can send the information to the neurosurgeon. They also is going to be happy. I'm going to downgrade the tumor. Maybe the treatment will change based on the new classification. And if changes, that might help for the patients as well. Fine. IHC. CD34 is the most important thing. That was appreciated in both things. OLIC2 has become very famous in this WHO classification. OLIC2 expression will be there. And now retain attracts. If it's not been lost, it's fine. And GFAP is going to be weakly positive. So it's a glial lesion. That's why we call them neuroepithelial lesion of the lung, right? So glial marker is going to be weakly positive here. And the most important thing is this. The surrounding neurites also will be CD34 positive. It's not just a tumor cell. The surrounding background also will have the CD34 positivity, right? So I hope you will be able to diagnose this condition in future. It's polymorphous low-grade neuroepithelioma of the young. Fine. Okay. Let's go to the second one. So that was one in the low-grade glioma. We'll have a quick look about one in the high-grade glioma as well. The high-grade glioma, we saw many of them like diffuse hemispheric glioma, diffuse glioma, 2 H3 mutated, 1 wild type, 1 IDH mutated, and infantile glioma, right? So you're just going to see diffuse hemispheric glioma. H3 is a histone mutated, G34 mutation in the H3 in the histone. Okay, so to diagnose this, you might be required to acquire the IHC of histone or send it for molecular genetics. Because histone IHCs are available, though it is a bit difficult to standardize them. If you are okay with that, please go ahead, and if you have a heavy load of neuropathology cases in your institute, please go ahead and do it. So this was the one case which was described in the article which gave up the WHO 2020 classification. It's a completely like a PNET like morphology, like a small round blue cell, and they have a very strong positive immunohistochemistry for my histone 3 G34 R by V variant. Fine. So if you have the IHC, my diagnosis straightforward. Otherwise, I can use the existing IHC, and with the background knowledge, I can go and diagnose this patient as well. If not, please send it for molecular genetics. Without molecular genetics, it will be difficult for me to diagnose them. I can suspect them, but I cannot write it out. Okay, it is diffuse hemispheric glioma, H3 G34 mutated. Fine. So the one thing is, this tumor also has lots of microscopic appearances. There are 4 classical microscopic appearances which are described. I have encountered everything, and I do have the images for all of them. Again from I think a neuropathology journal. I forgot the journal name, right? So I can have a PNET like morphology, like that what we saw initially, like a small round blue cell. They'll have anaplastic features. Generally a PNET will not be too much anaplastic. Here will have anaplastic lesions. Will have an endothelial cell proliferation. They are high grade for sure. They are negative for OLIC2. And as I said that OLIC2 has got a very important role in this WHO classification. They are positive for P53 and Atrax is lost. The same thing like when OLIC2 was expressed and when Atrax was retained, we have a low grade lesion. When Atrax is lost, I hope most of you will have Atrax IHC in your hospitals. So Atrax is lost and OLIC2 is also lost. I'm going to have a high grade lesion, which is also emphasized by the pleomorphism, anaplasia, endothelial proliferation, and my p53 positivity. Fine. And undifferentiated glial morphology. It looks glial-like. I'm not able to say where it is exactly fitting into, right? I have an irregular shaped nuclei, poorly delineated cytoplasm with anaplastic features. It's like an anaplastic astrocytoma, that's all. With anaplastic astrocytoma, in a pediatric population, it's positive for OLIG2 in the reactive glial cells, not in the tumor cells, fine? And attracts and p53 stainings. Then I can think of my mutated H3 variant, and I want you to do one molecular genetics, fine? I have a monstrocellular morphology. It's monstrocellular, right? They're just giving it a different name to make it sound more attractive, that's all. And multinuclear gene cell, lots of anaplasia. It's monstrocellular. Okay. Again, here you will have necrosis as well. Negative OLIG2 staining and positive for TP3 and attracts locks. Same like my PNAT morphology, right? They're going to have the same appearance like my PNAT morphology. That's I'm going to call it monstrocellular morphology. The fourth one is oligoid morphology, which looks like an oligodendroglioma. But please don't classify them as oligodendrogliomas. So oligodendroglioma like morphology, we'll have a look at layered reporting soon. So where the primary diagnosis morphologically looks like an oligodendroglioma with my clear perinuclear halo, anaplastic features, endothelial proliferation. So morphology wise, I'll think of an anaplastic oligodendroglioma. Mitosis more. My OLIG2 will be positive in my reactive cells. TP53 positive and attracts loss will be there. That's classical. So microscopy, the layered structure reporting says like that. Microscopy have a thing, an integrated diagnosis, a molecular diagnosis, and the grading system. These are the 4 things required in the layered reporting of the new WHO. We'll look at them soon. We'll have a detailed discussion about layer reporting soon. Fine. So we have 4 different types of morphology: PNET-like, undifferentiated glial, monstrocellular, and oligoid. This is the article which explains everything. See, the most important thing for me is attracts is retained in my second morphology, that's the undifferentiated glial morphology, but attracts is lost in most of the other ones. Okay, and OLIG2 is again lost in most of the other ones. Again, here in your oligoid and your undifferentiated glial morphology, the B and D, OLIG2 will be retained, but not in the tumor cells. It will be retained in the surrounding glial cells. How you can appreciate them is, see, the amount of positivity of OLIG2 here compared to my P53 is less. So the positivity is not the tumor cells, the reactive glial cells. But invariably, almost everything will have a very strong P53 positivity. So that I can keep it as a thing to say it's definitely a high grade lesion. Fine. So I have 4 morphologies: round cell morphology, and undifferentiated glial morphology, and monstrocellular morphology. This is a monstrocellular morphology, though it's a very low, a small image. Still I can see the pleomorphic giant cells here, right? Monstrocellular and an oligoid. Again, so it's a very small image. If you can strain your eyes, you can see the halo around the blue cells, right? So having a classical morphology, I'm going to do an IHC workup. I'm going to wait for my either IHC of the H3 G34 RBV or your molecular genetics of H3 Histone G34 Mutant, right? That's very important, right? And one thing which has been said, that is the diffuse K27 mutant should be reserved for only tumors which are infiltrating midline and shows K27 mutant, and not for my other things, because we had 2 diffuse gliomas, 2 H3 mutant, one was K27N, other was G34. So this K27N was also present in the previous WHO classification, and they said that please don't apply this for every tumors. If it's an ependymoma mutated for H3 K27N, don't report them as midline glioma. Please report only if they are gliomas which are infiltrating and should not be applied for any other tumors, because this mutation can be seen in many other tumors, like said here, ependymomas. Fine. Okay. Coming to the prognosis, again the purpose of reclassification for me is to make sure the prognosis typically it will be helpful, either the good or the worst. The mean survival of an H3 G34 glioma is better than those of an IDH wild type GBMs, the glioblastomas. Fine. That's very, very important. But my H3 K27 mutant glioma are worse than my IDH mutated GBMs, again wild type and GBMs. The thing why I'm using this is I want to disregard the diagnosis of glioblastoma in a kid, because these variants, when I'm very, very specific, I know what's exactly happening and I'll be able to give a perfect prognosis. I can exactly say this, how much they're going to survive, and if at all there, some molecular targeted therapy as well. We'll have a quick look. This is an update which came after WHO 2021. It is done in 2020 by Chen et al. So they have found that in the gliomas, which are my Histone G34 mutated, we have found lots of PDGFRA mutations. This is something good for me because they have said that this PDGFRA is the one which is going to primarily promote the glioma genesis, the tumor genesis, which is very good for me because PDGFRA is a very well-known mutation for us in your leukemias, the eosinophilic leukemias, and also in the GIST, where we had therapies against them. So what we did was we tried imatinib with these patients. This imatinib are not so perfect because they are first generation drugs, not so perfect, but there are definitely future drugs, avrapatinib, which are developed and by approved by WHO, which can be perfectly useful for my GIST, same PDGFRA exon 18 mutation. But if I'm going to apply them for this diffuse glioma, will they respond or not? The future will say. If it responds, it's very, very, very good for the patients, right? Okay. So these are two tumors we want to discuss. I'll have many series of videos, short videos on WHO 2021 classification. Hopefully we'll read together better, and hopefully we'll diagnose them better as well. Fine. And if you're a postgraduate student, do follow me in the Unacademy app. And there's a pathology group for postgraduates, a channel and a group. We are close to reaching to 1,000 students. Hopefully we'll be able to reach more students, and we'll learn more for pathology in the thing of diagnosis, not just from the entrance point of view. Fine. We're going to apply more concepts. I'm having a few good cases, and I'll share with you, and you also share the cases with me, and together we'll grow. And all these special classes hosted in the Unacademy will be free of cost. I'll be interactive, it'll be live. I'll ask questions, you can ask whatever you have. You can download the PPT, whatever I share, the images with you, all the slides, annotations, everything will be there. So you can use it later in life, because if you're not having enough time to take a note, you can just listen to them. You can just listen to them wherever you want, in your mobile phone or in your tablet or in the laptop. Fine. Hopefully we will slowly venture into NEET SS MCQs as well as your FRC Path MCQs, and that will help you guys as well. Fine. So thank you for your time. We'll see you soon with another video of WHO 2021 update. Till then, bye from Dr. Ranjith. Bye bye.